This week we're going to continue our respiratory discussion with the topic of ventilation. Ventilation is going to be the act of actually moving air into and out of the lungs. One of the topics we'll get into is gas exchange, where we see carbon dioxide and oxygen move across the respiratory membrane in opposite directions. In order to maintain that transport, to keep equilibrium between those two gases from happening, we have to continuously replenish the air that's inside the alveolar sacs with air from the environment. So there has to be an ongoing exchange. The movement of air into and out of the lungs from the environment is going to be the act of ventilation. So we're going to need to understand the mechanics of the rib cage, how it expands and changes its volume. We're going to need to understand the relationship between a pressure and a gas and the volume of that gas. That's what's going to move and drive that movement of air into and out of the lungs. Finally, we have to look at the importance of the pleural cavity. It's the pleural cavity that is going to create the link between the mechanics of the rib cage and the movement of the lung tissue itself, because both of those pieces of anatomy are not directly connected together. They rely on the integrity of the pleural cavity to make sure we make that translation. During resting ventilation, picture you're sitting here watching this video now, hopefully breathing at a nice, normal, relaxed rate. That's resting ventilation. That is only going to involve contractions of the diaphragm for inhalation. Diaphragm is a dome-shaped muscle that sits within the lower half of the rib cage, and as it contracts, it pulls down and initiates that inhalation stage of ventilation. Resting inhalation is only a diaphragmatic activity. When we contract the diaphragm, it's going to dramatically change the volume of the rib cage and ultimately change the volume of the lung tissue inside. Now, with that being said, resting exhalation is a purely passive process. You use the diaphragm to take an active breath in, or resting breath in. In order for you to do the other half of that ventilatory cycle, all you have to do is relax the diaphragm. As the diaphragm pulls down, it contracts and shortens. The ribs are going to expand up and out, slightly stretching the cartilage that connects the ribs onto the sternum and the ribs onto the spine posteriorly. Once you relax that diaphragm, it passively moves back up to a resting length. The rib cage, because of the elasticity in that hyaline cartilage, folds back in passively. So we require the diaphragm for a resting breath in. For a resting breath out, all we need to do is relax the diaphragm and everything will happen in a passive process. That's quiet breathing, relaxed breathing. The skeletal muscle is only going to get involved when we are actively breathing. Think about the ventilation that you would undergo during exercise. The ventilation you would undergo if you were yawning, coughing, blowing out birthday candles, blowing up a balloon, taking a deep breath in before you dive underwater. Those are all active processes that bring more air into and out of the lungs than we see move with a resting ventilation. And because of that, we have to recruit secondary muscles in order to pull that off. Now, here is a laundry list of the secondary muscles. And I'm not really looking for you guys to memorize the list, but you should see where they fall anatomically. Remember, muscle will only pull when it contracts. When it contracts, it shortens and pulls on whatever anatomy is on the other side. So when we look at where those muscles happen to lie, any of those secondary muscles that would be associated with the upper part of the rib cage is going to help lift that rib cage. We see the scalenes. We see the sternocleidomastoid muscle. When they shorten, the rib cage is going to be elevated. We see our external intercostals as they angle backwards. When they contract, they lift the rib cage outward. Now, conversely, we see where the abdominal muscles are going to be. Lower than the rib cage, inserting at a higher, more superior point. When they contract, they pull the rib cage back down. We see our serratus posterior muscles over here. When they contract, they pull the ribs back down. So get used to picturing this rib cage expanding as you take a deep breath in, and look at where the muscles lie anatomically, and it should be very intuitive. If that muscle shortens, is that going to lift the rib cage up and expand it, or pull it down and make the volume smaller? During inhalation and ventilation, the rib cage and the thoracic cavity are going to change three-dimensionally. We see the diaphragm contract and pull downward, increasing the dimensions of the thoracic cage from superior to inferior. We see the sternum move forward, increasing the dimensions from anterior to posterior. And we see the rib cage move up and out, increasing the dimensions laterally. So as you go through the ventilation process, we see all three dimensions of that rib cage go through fluctuations. Breath in, with the rib cage expanding outward, sternum moving forward, diaphragm pulling down, and as soon as you relax that diaphragm, everything passively happens in the reverse direction, increasing the volume with an inhalation, decreasing the volume as you exhale. Now, some of you guys that are going to be going into radiography will notice this on x-rays quite a bit. We talked about this in A&P1 just a little bit when we talked about different types of imaging to get a view of the anatomy. X-ray will always show more dense objects in white. The air-filled lungs are less dense than the tissue around it, so it tends to look very dark on a film. So you take a nice deep breath in, it pulls the diaphragm down and away, and we can see those nice, big, dark lung fields. As you let the rib cage relax, and the diaphragm moves back up, the thoracic cage gets smaller. You can see the diaphragm is elevated on our x-ray, and the lung fields got smaller again. So we breathe in, breathe out. Breathe in, breathe out, and we can see the lung fields on the x-ray changing as we go, as they get bigger and smaller. Now, we have a leap of communication right here. Everything we're talking about so far involves the rib cage and the diaphragm. And we know that the lungs sit just inside there. What we haven't done yet is connect those two pieces of information. There are no ligaments or any other hard, bound fasteners connecting the inside of that rib cage to the outside of the lung tissue. But we need to have a mechanism so that every time we expand the rib cage, the lung tissue inside expands as well. We get that from the pleural cavity. In order for rib and diaphragm mechanics to translate into lung tissue expansion and contraction, we need an intact pleural cavity. And within that intact pleural cavity, we see what's called a transpulmonary pressure exerted. That's what allows us to connect the dots. Remember when we looked at our pleural cavity before, we had our visceral pleura sitting right on the lungs. We had our parietal pleura sitting out from it, adhered to the inside of the rib cage, and the pleural cavity is just the space in between. You should know what we find inside that pleural cavity. We find a serous fluid. These are fluid-filled cavities. We mentioned the fact that one of the functions of this pleural cavity is to reduce friction. But especially for the lungs, we use the nature of the fluid inside. A fluid-filled cavity will always resist changes to volume. A fluid-filled cavity will always resist changes to volume. As we try and separate those two membranes, the pressure inside the cavity will go up dramatically, resisting that change. And that's going to be the character of the pleural cavity that allows for every time the ribs move, the lung tissue moves right along with it. Now remember, the lungs are not found inside the pleural cavity. Pleural cavity surrounds the lungs, and that's what makes this principle really effective. So as the ribs elevate and the diaphragm depresses, the internal volume of the rib cage goes up. As the ribs and the diaphragm move, picture they're going to pull on the parietal layer of that membranous cavity. And as it does so, it's going to ever so slightly begin to pull those membranes apart. But because we have a fluid-filled sac, as we start to move that parietal pleura away from the lungs, pressure inside that cavity goes up tremendously. And now we've got a war of two forces. We've got the forces involved with moving the rib cage up and out versus the forces of stretching the lung tissue. And we wind up getting the principle that rib cage expansion will always lead to lung tissue stretch as long as the forces needed to stretch the lung tissue are less than the forces needed to expand the pleural cavity. You move the ribs out, it starts to open up that cavity. Now you've got two different forces. How much force is it going to take to actually increase the volume of that cavity? Versus how much force is needed to stretch the lung tissue. And if the lung tissue stretches easier than the pleural cavity expands, everywhere where that parietal pleura goes with it, the visceral pleura will follow. So as you expand and contract the rib cage, the pleural cavity's distance between those two membranes stays the same. And as a result, the ribs move out and the lung tissue moves with it. So now we can start to talk about not just rib cage volume increases, but lung tissue volume increases. That's what connects the dots. We need to have an intact pleural cavity filled with fluid, and we use that transpulmonary pressure to translate rib movement and force into forces that are going to stretch the lung tissue itself. It's the same principle that keeps the lungs from deflating inside the rib cage to start with. Because not only are we able to move the lungs up and out when the rib cage moves, but even if you were to sit there and hold your breath, there's tension on that lung tissue. But the lung tissue itself is not able to pull away from the inside of the ribs, because if they do, they're going to be expanding their own pleural cavity. So the same forces that allow us to stretch the lungs as the ribs move are the exact same forces that keeps the lungs inflated up against the inside of the cavity. And we've all seen cases of a pneumothorax, or heard of cases of a collapsed lung. You get a penetrating wound into the side of the rib cage. It punctures the pleural cavity, and now in that case, you no longer have that intact cavity. Now you move the ribs up and out. You no longer have a closed cavity. It's easier for air to rush into the lung, the pleural cavity space than it is to stretch the lung tissue. Now you don't have a cavity fully filled with fluid. There's some air in there. And air has no trouble changing its volume versus its pressure. We can take all the air in the room I'm standing in and compress it down into a tank that fits on the small of your back so you can go scuba diving. We can change the volume of the gas very easily. And because now we have gas inside the pleural cavity, we lose that transpulmonary pressure. So now every time we talk about the ribs and the diaphragm moving, changing the thoracic cage volume, we know that the pleural cavity is intact, and we can translate that directly over into talking about lung tissue expansion and contraction, changing the volume of the lung tissue and all of the little alveolar sacs inside. Inside the alveolar sacs is gas. It's air. And when we look at Boyle's law, the relationship between volume and pressure of a gas is inversely proportional. If we take a unit of gas and increase its volume, the pressure inside goes down. We take that same volume of gas, now we make it smaller, the pressure inside goes up. So by manipulating the volume of the lung tissue, we manipulate the air pressure inside the alveolar sacs. And that's going to be critical for moving air into and out of lungs. Air will always move from a high pressure to a low. I know people don't watch cable TV anymore, but there was a time when everybody would tune in the night before to see what the weather was going to be like the next day. And somebody would stand in front of a big screen, and there would be a big line going through the center of it, and he would say, we have a high pressure system moving in over here, low pressure system moving in over there. He's talking about pockets of atmospheric pressure. You know, based on where the high pressure and low pressure is, how windy it's going to be and which direction it's going to be moving, because air will always move from a high pressure to a low. That's Bernoulli's principle. We use Bernoulli's principle to suck air into the lungs as we increase its volume and expel air back out of the lungs when we decrease its volume. Normal atmospheric pressure is round about 760 millimeters per mercury. All we need to do is change the air pressure inside the alveoli ever so slightly above or below the pressure of the air in the room, and we will see air move into and out of the lungs, respectively. So, the pressure inside the alveoli, represented by the wavy line. When we let the rib cage drop down and in, and the diaphragm comes up, we increase the pressure in the alveoli. We decrease the volume, therefore it's a gas, we increase the pressure. We increase the pressure above atmospheric pressure. The pressure here in the alveoli at that point in time is higher than atmospheric pressure. Air is going to move from the alveoli up the trachea and out the mouth or nose. We take the diaphragm and now we bring it down. The rib cage moves up and out and the volume increases. Inside the alveoli, a volume increase means the pressure decreases. It decreases below atmospheric pressure, and in this case, air will go from a high pressure to a low and fill up the lungs. So by manipulating the diaphragm and ribs, we change the thoracic cage volume cyclically. By changing the rib cage volume cyclically, because we have a pleural cavity, we can change the lung tissue volume cyclically. And every time we do that, we manipulate the air pressure inside the alveoli, and through Bernoulli's principle, can constantly, in a cyclic manner, exchange air with the environment in which we happen to be in. So it's important to be able to understand the mechanics of the rib cage first, understand how the rib cage movement translates into lung tissue stretch through the use of the pleural cavity, then move into looking at how that change in volume affects the pressure of the gases inside the alveolar sacs. And then finally, once we know how that pressure fluctuates, we can use Bernoulli's principle to explain why every time I drop my diaphragm down, air rushes into the lungs to inflate it. Kind of connect the dots and work it through that system, and it'll seem just a little bit easier for you. Now that we've gone through the lung anatomy, we've gone through the ventilation process, the next place we have to go is gas exchange and gas transport. We will see gases move into and out of the blood at two places. At the lungs, crossing the respiratory membrane, and at the tissues, crossing the capillary wall. So we'll talk about the concentration gradients and the diffusion of those gases at those two sites, and we'll talk about gas transport from one site to the next on how we can maintain those concentration gradients. Thank you.